Bismillah ar-Rahman ar-Rahim. This is the second lecture about the thyroid. I am Dr. Ayman Abdullah Abdurabu, Professor and Head of the Endocrine Surgery Unit in Shams University. The subject in this lecture is about simple goiter, the thyroid nodule, and principles of thyroidectomy. By the end of this lecture, we should be able to understand the natural history of the disease, gain familiarity with three key points: the risk of thyroid cancer, the risk of local compressive neck symptoms, the risk of hyperthyroidism, and to discuss the tools of diagnosis and the means of treatment, and discuss the principles of thyroidectomy. Now we start first by defining goiter. Goiter is surgically defined as enlargement of the thyroid gland. Can be classified into simple, which is non-toxic goiter, or toxic goiter, neoplastic goiter, and inflammatory goiter. What is this hyperplasia adenoma carcinoma syndrome? The continuous stimulation of follicular cells, or the cells of the follicles in the thyroid, by the TSH stimulation leads to its hyperplasia. This hyperplasia at one stage starts to lose its control. It takes its own growth independent from the TSH formation. So it grows in its way. It's a hyperplasia that is not controlled, that is no more physiological, and it progresses to form nodules, hyperplastic nodules. Sometimes it stores a large amount of colloid inside it to form a colloid nodule. On the other hand, it can turn into an adenoma. Then, in rare conditions, it turns into a carcinoma. It can pass from hyperplasia into carcinoma without giving an adenoma, or it can pass from a hyperplasia into an adenoma, and then the adenoma turns into a carcinoma. It's a chronic TSH stimulation syndrome. The chronic TSH stimulation syndrome, which gives this hyperplasia, it can lead to the development of a tumor at the end, or hyperplasia leading to increase in the function, which we call it an autonomous toxic nodule. It becomes a toxic nodule, autonomous. It secretes on its own, not controlled by the effect of the TSH anymore. So the chronic TSH stimulation syndrome can lead to hyperplasia, adenoma, carcinoma, or can lead to increased function and autonomous nodule, or can lead to both, an autonomous toxic nodule that can rarely be a malignant nodule. So the nodularity here is a chronic TSH stimulation hormone leading to the formation of hyperplastic areas, leaving the rest of the gland as hypoplastic intervening tissue. The gland increases in size, becomes irregular, having nodules, single or multiple. Early, the patient is either euthyroid or can turn into toxic, or later on can be hypothyroid. And of course, if it attains a large size, it can lead into pressure manifestations. Now it's time to define the thyroid nodule. It's a discrete lesion within the thyroid gland that is palpable and or ultrasonographically distinct from the surrounding thyroid parenchyma. This means that the thyroid nodules can be palpable and visible, or can be detected only by ultrasonography. Let us take a look about this. What is the prevalence of a palpable thyroid nodule? On average, in women it is 6.4%, and in men it is 1.5%, almost 4 times in women compared to men. And of course, its incidence increases with age, and incidence increases in the iodine deficient areas and commoner in patients with history of exposure to radiation. Why are we truly concerned with the thyroid nodules? 5% of the thyroid nodules are malignant. If we assume that the population are 100 million in Egypt, 6.4% of the females have nodules, palpable, other than the ultrasonography detectable. Consider it 6% of 50 millions, it is almost 3 million. 5% of these 3 millions can have malignant thyroid nodule at some time of their lives. 5% of 3 million, it's almost 150,000 malignant case in the females only at one time of their lives. On the other hand, the benign lesions, which are 95% of the cases, that can be just nodules of simple multinodular goiter or multinodular goiter, can be cyst, can be solitary hypoplastic, adenomatous nodules, thyroiditis, follicular adenoma, sometimes thyroiditis due to infection, toxic adenoma, thyroid cyst, or sometimes intrathyroidal parathyroid adenoma that is mistaken for a thyroid nodule. While the malignant nodules can be papillary thyroid carcinoma, follicular thyroid carcinoma. Both of them are called the differentiated primary thyroid cancers. And then the medullary thyroid carcinoma and the anaplastic carcinoma, really the thyroid lymphoma or secondary thyroid tumors or metastatic. We spoke a while ago about the palpable thyroid nodules and its incidence being 6.4% in females and 1.5% in males. How about an autopsy and in ultrasound studies? In autopsy, it's almost 50%, and about 35% of these nodules is 2 centimeters or more that are escaped during the clinical examination, not diagnosed. To that extent, yes, 50% of the autopsies samples showed thyroid nodules. 35% of these 50, almost 17.5% of all autopsy samples show nodules more than 2 centimeters. How about the ultrasound studies? Reports vary from 19 to 46%, while in the middle-aged female between the 30s and the 50s, it's about 50% that are detected by ultrasound that are non-palpable but ultrasonographically detectable. Additional unsuspected nodules up to 48% with a single palpable nodules means that the patient is presenting clinically as a solitary thyroid nodule, but ultrasonography in 48% of patients of solitary thyroid nodules prove that the patient has multinodular goiter rather than a solitary thyroid nodule. Now, how prevalent is multinodular goiter? In North England, the visible and the palpable nodules were found in 6.9% of the general population with a female to male ratio of 4:1. In Singapore, an average of 2.8%. But in Denmark, in mild iodine deficiency area and a high incidence of 9.8%, and in moderately iodine deficiency areas it reached 14.6%. This incidence is increased to 50 and 22.6% respectively when goiter is defined ultrasonography. Means that the incidence 9.8% and 14.6% are clinical diagnoses rather than radiological, which is almost doubled by ultrasonography. Now, how was this nodule found? How it was discovered? In many incidents, during the palpation of the neck, in the general examination for any other disease other than the thyroid, accidentally the doctor observes or finds by the inspection or palpation or both that there are thyroid nodules. In other incidents, during a CT scan, MRI, or ultrasonography over the neck for some spine or other disease in the neck other than the thyroid can be found to have nodules. Sometimes the patient himself or one of the relatives observes that there is a swelling in his thyroid or in his neck. During some surveillance studies in the endemic areas for goiters, these thyroids can be found to be involved by thyroid nodules. How about the workup for symptoms of hyperthyroidism? The patient might be coming for tachycardia or weight loss or anorexia or whatever hypo or hyperthyroid symptoms. And then during the investigations, he is discovered or she is discovered to have hypo or hyperthyroid. And of course, assessment of the thyroid by ultrasonography and other modalities can show that the thyroid are having nodules. Does it differ too much or clinically relevant if the patient discovered it himself or accidentally discovered? No, not much, unless that the patient is telling in the history that he was not noticing the thyroid nodule, or he had it for a long time but it was small, then suddenly it started to grow fast, or it appeared and grown fast in a short time. At that time it's clinically relevant, a rapid rate of growth, but otherwise how it is discovered is not that much important. Sometimes it is asymptomatic, it's just a swelling, or sometimes we discovered it, the patient didn't discover it. In other ways, the patient can be presenting with painful, quick onset swelling that might give an idea about a cyst or thyroiditis. Sometimes he can present with difficult swallowing, or pressure manifestations, or toxic manifestations, or malignant manifestations like hoarseness of voice, or change in a voice, or shortness of breath, difficulty in swallowing, especially if the patient is lying down in bed, which we call it Pemberton sign, and sometimes a choking sensation or irritative cough with tracheal infiltration can be a malignant symptom, plus the symptoms of hyper or hypothyroid status, which will be discussed in the next presentation. By physical examination, of course, it will be discussed in details in the clinical tutorials. By inspection, palpation, and the signs of malignancy about the presence of fixed, hard, sometimes tender thyroid, or the presence of lymph nodes, and the manifestations of thyrotoxicosis by the general examination and other signs related to the eye signs, and hyperreflexia, etc., which will be discussed in the clinical course in more details. When we are dealing with a thyroid from the surgical point of view, we always look about malignancy. So there are very important points to discover during the history and the physical examination. A history of irradiation. In this sequence, head and neck irradiation, whole body irradiation, or nuclear fallouts, like for example what happened in Chernobyl. We say always that radiation history is the most important risk factor in the thyroid cancer development. It is the only absolute one. For example, when we say that the patient age above 45 or below 45, it's a risk factor. The more the age, the higher the risk factors for the patient. But these are relative risk factors. The only absolute risk factor of malignancy is irradiation. And in this arrangement or sequence, head and neck irradiation is the most dangerous, whole body irradiation is next, and the fallouts, nuclear fallouts, is the third. Then the other points that are of crucial importance are the family history of thyroid malignancy, some hereditary syndromes, which we'll be discussing later on, that can carry a risk of malignancy in the thyroid, and of course a rapid rate of growth of the swelling, hoarseness of voice, and the presence in the clinical examination of cervical or supraclavicular lymphadenopathy and fixation of the nodule or the gland into the trachea or any of the surrounding structures. Any nodule or swelling in the thyroid that is 4 centimeters or more is considered a risk factor, and the incidence of malignancy is far higher. And of course, any solitary thyroid nodule is suspicious. So the clinical suspicion comes from the rapid rate of growth, the presence of malignant symptoms like hoarseness, the presence of suspicious lymph nodes, whether clinically or radiologically, the fixation of the gland, and large nodules 4 centimeters or more, and any solitary thyroid nodule is a suspicion. So thyroid nodules can be in differential diagnosis, just multinodular goiter, or thyroiditis with nodules like some advanced cases of Hashimoto thyroiditis, or cancer, primary thyroid cancers, or lymphoma, or secondary metastatic thyroid cancers, or solitary thyroid nodule, whether simple or toxic, autonomous, or substernal goiter or retrosternal goiter. Now, what are the hereditary diseases that we should think of it in suspicion for cancer thyroid in the family history? Some syndromes, especially the history of thyroid malignancy, which is of utmost importance. This is the most important. Some syndromes like the Mann syndrome and the Vermeer syndrome. Other syndromes away from the thyroid, like the familial polyposis syndrome, has an incidence of cancer thyroid, Cowden syndrome, and Carney complex. All these can have a hereditary basis of thyroid cancers. Of course, the family history of thyroid malignancy and the Mann syndrome are of utmost importance. Now we will discuss step by step, in a case of a thyroid disease, how are we going to investigate. As usual, we will start with the laboratory. The routine laboratory investigations with the thyroid is to do a thyroid profile, 3T3, 3T4, and serum TSH. Sometimes in special cases like Graves' disease, What we called in the past the long-acting thyroid stimulating hormone, now called the thyroid stimulating immunoglobulins, can be measured. This is for academic studies, not in clinical practice. But in thyroiditis, the thyroid antibodies can be measured, and sometimes the cholesterol, especially in hypothyroidism, can be elevated. In routine practice, whenever we have a patient with a thyroid nodule or a thyroid disease, we go directly into two tests. Number one, TSH. Number two, thyroid ultrasonography. Why TSH? Because TSH is the ultra-sensitive. It's the most sensitive of all thyroid hormones, and it can reflect if it is hypo or hyper or subclinical hypo or subclinical hyperthyroidism. If there is a change of the TSH, we can proceed to do the rest of the hormones and the rest of the laboratories. If the TSH is normal, no need to do any other hormones. Why the thyroid ultrasonography? We'll explain it in a while. But we go into the radiological investigations, which includes a plain chest X-ray. It can show the deviation of the trachea. Sometimes the retrosternal goiter can be shown. Iodine isotope scan or technetium isotope scan can be used to diagnose the status of function, and if these nodules are cold, hot, or warm nodules. We'll discuss it in a while. The CT scan can be used sometimes because it gives us the topography of the gland. It can tell us how big it is, if it is extending retrosternally, how far it goes deep, behind the trachea and the esophagus. So it gives us the topography and expectations about how difficult will be the surgery. And the degree of tracheal compression or sometimes infiltration of the trachea or infiltration of the surrounding structures. It can also be evaluated by the ultrasonography, but CT, in fact, can be more informative in this. But the evaluation of the nodule itself, the gold standard is always the thyroid ultrasonography. We use sometimes some endoscopic investigations. Of course, laryngoscopy is mandatory for all thyroid cases to assess the vocal cords, whether they are involved or not. Rarely we can use bronchoscopy to see tracheal compression or infiltration. Usually we don't use it. Routine CT can be enough in most of the cases, but laryngoscopy, indirect or direct by fiber optic, can be used, should be used in most of the cases. Again, biopsy by fine needle aspiration or trocar biopsy. We will discuss this in a while in details. But so what is the value of thyroid ultrasound in thyroid diagnosis? The ultrasound diagnosis of the thyroid, first, it describes to us again the topography or the size, the relations of the thyroid gland, its relation to the important structure like the carotid sheath and its contents and the surrounding muscle and the trachea. Again, it differentiates between a solitary thyroid nodule and the multinodular goiter. Then the proper evaluation of the thyroid nodules regarding its characteristics, which we will discuss in a while. And finally, it gives us mapping of the draining lymph nodes, and it gives us an idea about is it looking normal, reactionary, or suspicious of malignancy. And it is superior to the CT scan and to the MRI in this field of diagnosis of the lymph nodes of the neck. Now, what are the characteristics of the thyroid nodules on ultrasonography? It can be looking benign or looking malignant. The benign characteristics include a pure cystic, which is relatively rare, and its incidence of malignancy is very low, less than 1%. A spongiform appearance, more than 50% of the nodule volume, aggregation of multiple microcystic components, and again, it's a benign one. A multinodular goiter, when the nodules are almost of the same size, there is no dominant nodule, and the nodules are not big, not reaching to the degree of 3 or 4 centimeters, where the equal in size nodules having no malignant criteria are usually benign. Here is an example of the septated cyst, a pure cyst where the arrow is pointing to it. Another cyst, which is a clear benign cyst. A thyroid ultrasonography and the side view of the neck of the patient showing a large nodule on the left side of the neck of the patient. A large nodule like this, which is involving almost the whole lobe, and it's a solitary one, should be always suspicious. Another benign lesion finding in the thyroid is what we call a halo around the nodule. It's like the breast in the soft tissue mammography when we find a halo, clear halo around the nodule. It's one of the sure benign lesions. Also look for the transverse versus the longitudinal diameter of the thyroid nodule. If the nodule is wider than taller, its transverse diameter is more than the longitudinal diameter, then it is benign. If it is taller than wider, it's most probably malignant. In these nodules, if it is large and a fine needle aspiration is taken, it's usually non-conclusive or benign, and follow-up ultrasonography after a few months can confirm the diagnosis, and then the ultrasonography will be repeated at longer intervals. Now, what are the considerations to be taken during ultrasonography, to stress upon during ultrasonography? Number one, the high-risk history. History of thyroid cancer, history of radiation, especially in the childhood, and previous thyroidectomy or exposure to radiations, repeated CT scans, PET scans, or suspicious scans like cold nodule, and suspicious features in the ultrasonography. What are the suspicious lesions in the ultrasonography? Microcalcification, a hypoechoic nodules, its density is less than the surrounding normal thyroid tissue, increased nodular or intranodular vascularity, not peripheral vascularity, infiltrative ill-defined margin, taller than wider on the transverse view. These criteria collectively make what we call TI-RADS scoring, like the BI-RADS of the breast. We have a score that can be calculated that gives us an incidence of suspicion whether this TI-RADS 1, 2, 3, 4, 5, or 6 if a biopsy is taken and proven as malignant. Fine needle aspiration cytology should be obtained from these thyroid nodules, and if a suspicious lymph node is found on ultrasound scanning of the neck. In cases of unacceptable biopsies, or as we will discuss later, that is inconclusive, it can be repeated, or the ultrasound can be repeated after few months, as we will see now. Now again, the suspicion is hypoechogenicity compared to normal thyroid tissue, increased intranodal vascularity, irregular infiltrative margins, a presence of microcalcification, absent halo, and taller than wider, any nodule more than 4 centimeters, any solitary nodule, and the presence of malignant symptoms like difficult swallowing can be suspicious findings. Now, to take a biopsy or not to take a biopsy. What are the lesions that are suspicious for us? Number one, any solitary thyroid nodule is suspicious. Number two, any dominant thyroid nodule that is bigger, faster growing than the rest of the nodules is suspicious. Number three, any nodule 4 centimeters or more is suspicious. Number five, thyroids 3 or 4 or 5 nodules that are 1 centimeter or more, according to the American Thyroid Association, and according to the European Thyroid Association, 5 millimeters or more. The American are more conservative than the European Thyroid Association. Here is a hypoechoic nodule pointed by the arrow. Now increased intranodular vascularity by duplex, microcalcification, the long arrow, and ill-defined margin and absent halo, the 4 arrowheads. Multiple thyroid nodules. When to take a fine needle aspiration, it's any nodule that is thyroid 3 if or more, if it is more than 1 centimeter, thyroid 2 if it is more than 1.5 centimeter. The suspicious criteria according to thyroid scoring: any dominant nodule, any solitary nodule, and the large 4 centimeters or more nodules. The suspicious nodule should be fine needle aspirated. Now, fine needle for palpable nodules or ultrasound detected nodules. As we said, it's not only the size. The size only, if it is 4 centimeters or more, it is highly suspicious. But any thyroid scoring 3 or more when the nodule is 1 centimeter or more, or 1.5 centimeters, thyroids 2 should be biopsied, and any solitary nodule should be biopsied, and any dominant nodule should be biopsied. Okay. When there is a thyroid nodule and the TSH is suppressed, we said that the TSH is ultra sensitive. So TSH suppressed means that the thyroid hormones are expected to be high, or this is a subclinical thyrotoxicosis. It is either clinical or subclinical thyrotoxicosis. In these cases, we do an uptake scan to assess if it is an autonomous nodule. If it is a solitary nodule, we call it autonomous toxic nodule. It doesn't mean that we will not do an ultrasound. You have to evaluate the function and the topography or the characteristics of the nodule by ultrasonography also. And we should consider in non-functioning and isofunctioning to take a fine needle according to the thyroid scoring, and even in the hyperfunctioning we should, if the thyroid scoring is high, take a fine needle aspiration. So why are we doing the iodine or technetium scan? In fact, in the past, we were saying that a cold nodule is suspicious of malignancy, a warm nodule is rare malignancy, and a hot nodule is almost never malignant. This is changed by the middle of the 90s when M.D. Anderson gave statistics about a solitary thyroid nodule study where they found that 11.74% incidence in cold, warm, hot solitary thyroid nodules. They said that the incidence of malignancy in cold nodules is 11%, in the warm nodules is 7%, in the hot nodules is 4%. 4%? Yes, 4%. So it's not almost never, it's not very rare, it's 4%. So any suspicious nodule on ultrasonography, even if it is hyperfunctioning, should be biopsied. So we have to evaluate the nodule by the thyroid scan and by ultrasonography. Why thyroid scan if we are going to make ultrasonography? Especially if it is it is a solitary nodule and TSH is suppressed, because we call it an autonomous toxic nodule. If it is not suspicious for malignancy, then the treatment of choice is radioactive iodine ablation of the nodule versus a lobectomy. It is an autonomous nodule that can be removed with the lobe, not total thyroidectomy. The rest of the thyroid gland is normal and even suppressed, so we'll leave it. Or radioactive iodine. This or that, it's some decision to make it with the patient. But the treatment of choice in autonomous nodule, toxic nodule, is the radioactive iodine. That's why we do the thyroid scan. We never forget to evaluate the nodule by ultrasonography, because malignancy can take place in the toxic nodules. Now, fine needle aspiration or true cut needle biopsy. Of course, it's fine needle aspiration, and the American Thyroid Association and the European Thyroid Association, the Japanese Thyroid Association, all considered that the gold standard biopsy is the fine needle aspiration cytology, not the true cut. Why? Number one, its accuracy is very high in the hand of the trained pathologist. Number two, it's safe compared to the true cut biopsy. It's not like the breast. The thyroid is located in the neck, close to major vessels, close to the trachea. Serious injuries can happen during taking a biopsy with the true cut needle. Again, the tissue biopsy has only value if I am going to diagnose the difference between follicular adenoma and follicular carcinoma by vascular invasion and capsular invasion. Actually, true cut needle biopsy is not adequate to show this, because to differentiate between follicular adenoma and the follicular carcinoma, I have to find this invasion at many sites regarding the capsular invasion, not at only one entry by the true cut needle, which cannot be affected practically. So with a high accuracy of the fine needle and more complications of the true cut needle, it's safer and better to do a fine needle aspiration rather than the true cut needle biopsy. Now, the only gold standard for proof of malignancy without surgical pathology is the fine needle aspiration. So, how accurate? Its false negative ranges up to 5%. In some centers, it's far less than this. And its false positive is extremely rare, less than 1% of cases. So when they say it's malignant, it's malignant. Again, in the lymph nodes, a fine needle pathology or cytology coming to tell you that this is thyroid tissue in the lymph node or a papillary thyroid carcinoma, it's a metastatic disease in the lymph nodes 100%. Now, also the fine needle aspiration can be false high in the large nodular, false negative, high false negative in the large nodules, because in nodules 4 to 5 centimeters, it's not necessarily that it's all the nodule is malignant. Though the risk of malignancy is very high in these nodules, it's not necessary that the whole nodule is malignant. So the biopsy may not hit the target. So a higher false negative can be affected in this. But for us, a nodule that is 4 centimeters or more, even with a negative or a false negative, we don't proceed into follow-up. We proceed into at least a lobectomy or sometimes directly into a total thyroidectomy. Why? The incidence of malignancy is very high. If the malignancy involving the whole mass, which is a 4 centimeter, then it is T3. It exceeded 4 centimeters, so it's justified to have a total thyroidectomy rather than a lobectomy. So if the biopsy is negative, we will go again for surgery in tumors or masses or nodules 4 centimeters or more. And it should be put into consideration that larger nodules are usually associated with pressure symptoms. So, is size a predictor of malignancy? No, it can be big and benign. It can be small and malignant. But according to the American Thyroid Association, we don't take a biopsy from a sub-centimetric nodule. And according to the European Thyroid Association, we take it starting from 5 millimeters if it is thyroid 3 or more. What about the results of the fine needle aspiration? There is something called the BCEDA system of reporting thyroid cytology. BCEDA classified it into 6 grades. Grade 1 is non-diagnostic. We call it hypocellular. The sample is not adequate. Grade 2 is benign. Grade 3 is atypia of undetermined significance, or we call it indeterminate. 4 is suspicious for follicular neoplasm, and the follicular neoplasm can be follicular adenoma or carcinoma, which we cannot differentiate between it by needle biopsy, and suspicion of malignancy, which is grade 5, and 6, it's typically malignant, as we see here. Now, the diagnostic category, if it is non-diagnostic or satisfactory, you can tell the incidence of malignancy. So ultrasonography guided fine needle aspiration should be repeated. In the benign, which is BCEDA 2, its incidence is less than 3%. Follow up clinically with ultrasound after 6 months. Indeterminate, which incidence is an average of 10%, 5 to 15%, repeat the fine needle aspiration immediately or shortly after 3 months. If the same results and suspicious like that, indeterminate, we do go into allopectomy. Follicular neoplasm or suspicion of follicular neoplasm, we go directly into allopectomy, because follicular neoplasm can be follicular adenoma or follicular carcinoma. A follicular adenoma is precancerous. So in all ways, it should be excised, whether an adenoma or carcinoma. So if it is carcinoma, are we going to do a completion thyroidectomy, or is it better to do total thyroidectomy from the start? This is a debate that we should discuss it in the presentation about cancer thyroid. When we do lobectomy in cancer thyroid, and when we should do total thyroidectomy in cancer thyroid. So there are some malignant cases that we can do lobectomy, and it can be adequate. Now, suspicious for malignancy, here is what I say. Its incidence of malignancy is ranging from 60 to 75%, and we go either directly for total thyroidectomy or into a surgical lobectomy, and this is according to the risk stratification of the patient, which we will discuss it with the thyroid malignancy presentation. Of course, for malignant thyroids, we go again for total thyroidectomy or partial thyroidectomy, or the lobectomy, according to the type, the age of the patient, the risk factor. Risk stratification will decide for us what type of surgery we should do for the patient. So, in general, to assess a patient, we do a routine lab study, and there are some parameters that are very important in any thyroid, which is namely the TSH as the primary hormonal study with the thyroid ultrasonography, and the thyroid antibodies or thyroid peroxidase antibodies in thyroiditis, thyroglobulin as a tumor marker in differentiated thyroid cancers, calcitonin in medullary thyroid carcinoma if suspected, or for follow-up or screening of the families of patients with medullary thyroid carcinoma, which we will discuss later in the presentation of the thyroid cancers. Now, the algorithm of management of these thyroid nodules, if we do a fine needle aspiration in nodules, ThyRad 3 or more, 1 centimeter or more, or ThyRad 2 if it is 1.5 centimeters or more. If it is benign, we will examine sonographically again after 6 months, and if no change, we will repeat the examination after many years. The American Thyroid Association say 2 years, other protocols say 3 to 5 years. If we do a follow-up thyroid ultrasonography and there is an increase in size, in diameter, by more than 20% in at least 2 dimensions, or by 2 millimeters or 50% increase in the volume, then re-aspirate the thyroid nodule, follow the protocol of fine needle aspiration from the beginning. And if it is still suspicious, a lobectomy may be indicated as a diagnostic tool for histopathological assessment. So when we go and we proceed to do a radioactive iodine uptake scan, generally radioactive iodine uptake scan is used only for post-total thyroidectomy in cancer thyroid patients. Now we can do a radioactive iodine scan or a technetium scan, which is safer and cheaper in cases of hyperthyroidism, especially if it is a solitary toxic nodules. And again, its information is basically in the hyperthyroidism. Is it an autonomous toxic nodule, or it can be a cold nodule with an incidence of malignancy or of almost 10%, which is not too much accepted nowadays, because the gold standard is the ultrasound evaluation. Again, only in hyperthyroidism or post-total thyroidectomy in cancer thyroid patients, we use this radioactive iodine uptake scan. Now, surgery and thyroid cancer. Surgery, thyroid cancer is especially the differentiated types, which represents almost 90% of all thyroid cancers, is usually of low mortality. Differentiated thyroid cancer show low mortality, yet there are exceptions. On the other hand, the operation is not without morbidity. We should put the weight of mortality versus the morbidity. So if surgery is required, as an experienced surgeon should do the procedure, so not to cause serious complications to the patients. Like putting a drain or not putting the drain, making an ugly scar, and like morbidity for the patient can be too simple for us, and it's too big for the patient, like how the wound looks. We have to respect, of course, the need of the patient, and we have to understand that the patient is seeing from outside, not from inside. So taking the decision of surgery in the thyroid should be weighed against the benefit and versus the morbidity, and an experienced endocrine surgeon should perform the surgery. When to go into an endocrinologist or surgery? A general practitioner or someone who is not an endocrinologist or endocrine surgery refer any patient with thyroid disease if a child, pregnant, large nodule more than 1 centimeter, especially with suspicious features, thyroid 3 or more, have compressive symptoms, or have thyrotoxic or hyperthyroid symptoms. He can follow up if the nodules are small or show no exchange on ultrasonography after 6 months, and the laboratory and the ultrasonography are satisfactory. And ultrasonography should be done even if the patient is presenting with CT and Doppler, etc. The ultrasound and the TSH are the diagnostic tools number 1, 2, 3, and 10 in the thyroid. Endocrine or surgery. Always, when do we operate on the thyroid? We operate on the thyroid on suspicion of tumors or diagnosis of tumors, benign or malignant. So malignancy or the predisposition to malignancy. Number 2, pressure manifestations, huge goiters causing compression of the trachea or retrosternal goiter. Number 3, some cases of toxic goiter, which will be discussed in the next lecture, and in extremely rare cases of thyroiditis. But the main indication is the suspicion of or the proof of malignancy. In some cases of pregnant, we may need to operate, and if surgery is indicated, then we refer to surgeon. If surgery is not indicated and the patient is pregnant or a child, an endocrinologist should follow up the patient until the need for a surgeon is arises. So always refer the patient first to an endocrinologist, and selected cases will be referred for the surgeon for a definitive surgical treatment. Now, what about the principles of thyroidectomy? When we are going to do a thyroidectomy, of course, we prepare the patient if he is toxic by antithyroid drugs to make him euthyroid before the surgery. If it is a simple toxic, non-toxic, then the patient can go to the operation without preparation. But there are other preparations that, like the routine investigation of the patient, we should put the patient into surgery in the best condition. At OR, the patient lies in the supine position with a pillow under the shoulders, extended and fixed, extended neck and fixed head, sterilization of the field, starting from the lips of the patient, the sides of the neck and the whole neck, and the upper chest up to the nipple level, then prepping and draping of the patient. We start the operation by low collar incision as shown in the figure. Then we elevate a flap, we'll see it in a while, in the subplatysmal plane, the relatively avascular plane. Then we split the strap muscles in the strap muscles in the midline as seen here, to split it by opening the investing layer of the cervical fascia, and then we start to deliver the thyroid lobe and proceed into the operation. In this slide, we are showing how to elevate the flap in the subplatysmal plane and to dissect in a relatively avascular plane. The length of the incision, of course, is proportional to the size of the gland and the size of the neck of the patient. We try to make the smaller incision possible for cosmetic purposes. Then after elevation of the flap, we split the strap muscles in the midline. We started to deliver the loop of the thyroid on one side. Usually we start to the right. We take care of the middle thyroid vein, not to cut it. It's short, stout, and it can be avulsed, causing troublesome bleeding. So we identify it, we secure it, ligate it, and divide it, then complete the delivery of the loop. This is the first thing that we deal with. First vessel to ligate and divide is the middle thyroid vein. Then after that, we go to the upper pole of the thyroid gland. The field here is showing you the superior thyroid artery, which is visible here, and the superior thyroid vein, which is visible here beside the artery, going to the upper pole of the thyroid gland. So it's quite clear now what I explained in the previous presentation about the close relation between the artery and the vein and the external branch of the superior laryngeal nerve, which we call it the external laryngeal nerve. It's two branches here going to the cricothyroid muscle. So if we ligate the vessels high up away from the gland, we ligate this area all, then the nerve will be involved with us. But if we ligate the vessels close to the upper pole or even within the substance of the upper pole of the thyroid, then we are far from the external branch of the superior laryngeal nerve. It will not be ligated. So the second to be ligated is the superior thyroid vessels, artery and vein close to the upper pole or even at the substance of the upper pole of the thyroid gland to avoid injury of the external branch of the superior laryngeal nerve. Now we have to define the recurrent laryngeal nerve and the inferior and the superior parathyroid glands. Here is the superior, and here is all the inferior parathyroid gland. They should be dissected and secured. Remember what we said, that there is a close relation between the recurrent laryngeal nerve and the inferior thyroid artery. We will see that in the next slide. So we have to identify the recurrent laryngeal nerve, secure it, not to injure it, before we ligate the inferior thyroid artery. Why? We can safely ligate the inferior thyroid artery close to the carotid artery. As we see here, the carotid artery is here. If we ligate the nerve here, the artery here, the inferior thyroid artery here, we are far from injuring the recurrent laryngeal nerve. But what will happen? We will devascularize the parathyroid glands. Their blood supply is coming from the inferior thyroid artery. So the best is to identify the nerve and then go close to the thyroid gland and secure the branches of the inferior thyroid artery on the capsule of the gland away from the nerve, and meanwhile close to the thyroid gland to secure the recurrent laryngeal nerve and the blood supply of the parathyroid gland. After this is effected, the thyroid lobe is reflected medially and dissected from the trachea. Then we proceed to go on the other side to ligate the middle thyroid vein, then the superior thyroid vessels, then expose the recurrent laryngeal nerve, then dissect the parathyroids and ligate the branches of the inferior thyroid artery on the thyroid gland to preserve the blood supply of the parathyroids, reflect the thyroid lobe again medially. Then the final step is to ligate the inferior thyroid veins. Why we ligate the inferior thyroid veins as the final step? Number one, it is the main venous drainage of the thyroid gland. If I ligate it before ligating the arteries, the gland will be engorged. Number two, to effectively ligate these veins without injuring the recurrent laryngeal nerve on either side, I have to explore the recurrent laryngeal nerve on both sides to be safely ligating the inferior pole of the gland, the inferior thyroid vein. So it is the last thing to be ligated. So what we ligate and what we preserve. We ligate the middle thyroid vein first, the superior thyroid artery and vein together. Second, close to the upper pole or even in the substance of the upper pole to preserve the external laryngeal nerve, and then the branches of the inferior thyroid artery on the thyroid capsule to dissect the parathyroid glands safely without cutting its blood supply. And then finally, we ligate the inferior thyroid veins. What to preserve? Number one, the external laryngeal nerve. Number two, the recurrent laryngeal nerve. Number three, the parathyroid glands. Now, what are the final steps of the operation? After we have effected removal of the gland, we start to close the strap muscles in the midline. Then after that, we put a drain in the bed of the thyroid gland, and after that we close the platysma, and then we close the skin in cosmetic sutures. What are the important complications of thyroidectomy? The special complication of thyroidectomy is intraoperative bleeding and the possibility of recurrent laryngeal nerve affection, devascularization or excision inadvertently of parathyroids, which will manifest in the postoperative by hypocalcemia, and the recurrent laryngeal nerve will manifest in the postoperatively either by hoarseness of voice, aphonia, or even laryngeal obstruction and stridor according to the degree of injury, unilateral or bilateral, partial or complete. And of course, the one of the most fatal and serious complication is the pretracheal hematoma if bleeding takes place in the post-operative period, where it compresses on the trachea and in the internal jugular veins, leading plus the bleeding and the hypovolemia. But the more serious is the obstruction of the airway due to laryngeal edema and tracheal compression, which can kill the patient very fast. So an emergency on bed before taking the patient to OR, you have to open the wound fully to release the hematoma, pack the wound, take the patient to OR, intubate the patient, and then proceed to control the bleeding. I hope I summarized the principles of thyroidectomy in an adequate way. Thank you very much, and meet you in the next presentation for the thyroid.